Hello, this is Jeff Hauk. This is Foot and Ankle Orthopedic Lecture 2023. So we're going to address differential diagnosis first and get into treatment. The first things we're going to talk about is Achilles problems, including non-insertional rupture. Then we'll move on to posterior tibial tendinopathy and plantar fasciitis. So Achilles tendinopathy is really two different problems. Mid-portion are non-insertional and insertional. Mid-portion is usually almost exclusively a running injury from overuse or tendon overload. And where insertional is really a combination of three things. It's a friction problem with the bone, a bursitis, and tendinopathy. So when you look at somebody clinically, you immediately kind of know which it might be by where its location. So we're looking at the Achilles tendon from the posterior heel. We notice the insertion here. This is essentially the Achilles, and then B would be pointing at the insertion. And then about 6 centimeters proximal, we can kind of see A is pointing at this kind of mid-portion or non-insertional site, which we tend to see kind of a deformity or a lump in the tendon, and that's associated with non-insertional tendinopathy. Here's an ultrasound image of two different tendinopathies, and you can kind of tell here on the superior one, we have the shadow of the calcaneus here, and then we can kind of see the insertion. Well, this is pretty normal tendon, and then we go pretty far proximally to the right, and that's pretty normal. And we see this big kind of darkened enlargement in the tendon, and that's tendinopathy, and that's a non-insertional tendinopathy. That's pretty significant. And then we see on the inferior side or lower image labeled A, we can kind of see the same thing. Here's the normal kind of tendon looking up here, and then it gets larger as we get closer to the distal insertion. We can kind of see it gets really large then just before it inserts. So that's tendinopathy in the tendon distally. So two different types of tendinopathy, insertional and non-insertional. So we're going to talk about non-insertional first. So you can see it mostly occurs in runners, almost exclusively associated with sports. It's unusual or rare to have anyone that's inactive acquire this problem. It's the fourth most common running injury, and we can kind of fourth and very common foot and ankle injury. And we see here's an MRI. We see tibia, talus, calcaneus here. Normal tendon here at the insertion, and then this kind of enlargement with some white signal in the tendon indicating some unorganized tissue and potentially some changes in the mechanical properties of that tendon. Here's, in contrast, another MRI. This is a T1 weighted image, so we can kind of see here's the darkened bone with the tibia, the talus, the calcaneus, and then the fluid here in white, and then we can kind of see the edge of the bone here is pretty shaped on the back of the calcaneus, or sharp and pointy. That's called a Haglund's deformity. And then we also see some white signal, which could be a retrocalcaneal bursitis, and then we see thickening of the tendon, the Achilles tendon here. So it's insertional tendinopathy is really all three of those at some level. The other piece, this is a study that Ruth Chimenti and I did a few years back that's unique about insertional tendinopathy. There's a lot more bone inside the tendon as it's trying to repair. You can kind of see here's a bunch of examples of that. So here's on x-ray, there's bone sitting away from the calcaneus, which means it's in the tendon. Here's on the ultrasound image, you can kind of see that same kind of bony invagination here. Here's some whitened tissue that is bone inside the tendon, and then another clip here on the x-ray, and then here's a piece of bone that's showing up in the tendon on the ultrasound. So real different pathology and a different healing response of the pathology. Just to give you an idea of the insertional tendinopathy and how it can progress, there's this nice study from a few years back showing how MRI can capture the progression. So again, we have the tibia, the talus, and the calcaneus. You can kind of see the Haglund's deformity here, that sharp back part or superior, posterior part of the calcaneus, the thickening here of the Achilles tendon, and then here's the normal kind of thickness of the Achilles tendon. So the tendinopathy with the Haglund's deformity, this particular picture, there's not much bursitis or inflammation of the bursa. We can have now, look at this again, we see the tibia, talus, calcaneus, the Haglund's deformity, now a nice white signal there that indicates a bursitis, and then thickening of the tendon that extends quite far, approximately actually, indicating the tendinopathy. So there's the trifecta, and then as we kind of progress and it gets a little bit worse, we can kind of see the talus again. Here's the calcaneus. Again, we can see a pretty significant Haglund's deformity, a large amount of fluid indicating bursitis. And now we see not just thickening of the tendon, but also discoloration of the middle of the tendon, indicating there's fluid in the middle of the tendon as well, or degeneration of the tendon that's filled with fluid. And so this level of tendinopathy may not be responsive to exercise. So a good look at the pathology as it would progress for insertional tendinopathy. So it's very common in insertional tendinopathy to remediate this problem with surgery. And you can do a percutaneous removal of the Haglund's deformity, which we kind of see here on the right as the Haglund's deformity, and this is a really sharp looking one that would potentially dig into the tendon and cause the tendinopathy and irritation of the bursa, which would then result in pain. So by removing the Haglund's deformity, it's a fairly non-invasive procedure, and it can have a significant benefit. It may also have to be coupled, however, with a tendon repair, and in that case, the rehabilitation, which would be extensive. So, and then just some comment about the ankle range of motion tests and functional tests. We'll learn, you should know the lunge test, some approaches to foot range of motion, which we'll do in lab, and then the supine dorsiflexion range of motion test, all for just assessing how much range of motion there is, which we would expect at least 10 degrees clinically to be in a zone of most functional activities. One of the things that becomes clear, though, is with non-insertional tendinopathy and insertional tendinopathy that difficulty with stair ascent or descent. And with insertional tendinopathy, there's both stretch and compression of the tendon over the Haglund's deformity. So downhill or uphill running and stair descent increase dorsiflexion, which combine to kind of irritate the bursa and potentially cause pain. So insertional and non-insertional tendinopathy is real different pathologies. You could get a sense here of the kind of a palpation that would identify one or the other. You also get a sense of what kind of movements might identify one or the other, and then how they might respond to treatment given the pathologies that are occurring. So some study questions for us to review. And then finally, diagnosis of Achilles tendon ruptures. So Achilles tendon ruptures are not common in young people, even people that play sports, even though we see them, right along in, high intensity sports like football. But they really aren't common until people get to middle age. That means 30s to 50s. And so what typically happens too is that they're not associated with tendinopathy. So tendinopathy doesn't progress to the point of rupture. There's no known cases that have been reported in the literature, and there's no cases that I know of clinically that people have shared with me, and I haven't experienced them. So I would say rupture is really distinct from tendinopathy. So typically the way it occurs is you're playing tennis or some sport where you're running around and you go to land on your back foot into dorsiflexion with a high load. You hear a pop and you turn behind yourself and ask who threw their racket at me or who hit me, because it feels like someone smashed into you, and that's a typical history of an Achilles tendon rupture. The exam procedures are pretty straightforward, but they're subtle. So what I've done here is attach two videos that are about 30 seconds long each that demonstrate the Thompson test and the Maddles test, which are really pretty sensitive to being able to detect an Achilles tendon rupture and or, especially in the case of the Maddles test, a repair that hasn't restored the length properly in the tendon. And the same thing for the Thompson test. So they're really good tests to know, not just to diagnose it, but also to assess length of the repair after the surgery is over. What you'll see immediately is a palpable gap, typically where the tendon used to be. You'll be able to put your fingers in it, and you'll see the loss of contour, because there's not a tremendous amount of swelling in many patients that have this rupture. Passive ankle range of motion may be increased, and definitely ankle plantar flexion range of motion is decreased. However, it's not zero, and so hopefully you can answer the question of why it's not zero. So this should just give you some tips on how to differentiate clinically insertional, non-insertional, and a rupture from each other. And so now what we're going to do is start to talk about treatment for insertional and non-insertional. And the first important thing is prognosis about both of the diseases, these kind of tendinopathy problems. And so non-insertional is what this article is about, and essentially most patients with non-insertional tendinopathy get better. This is a 5-year follow-up, and universally the patients were improved even with just exercise or somewhat of a wait-and-see kind of approach, right? Now, for insertional, it's somewhat different, right? Because we know we saw the deformity is combined with the tendinopathy, so it's not just a tendinopathy. So sometimes the bone needs to be removed in order to achieve a pain-free or kind of functional state for the tendon. So insertional tendinopathy has a less positive prognosis than non-insertional. Non-insertional almost never goes to surgery that I know of, but insertional tendinopathy, those individuals end up with surgery, quite a bit. So 50-50 or somewhere near that. So what exercises that we give, and this is the mainstay, especially for non-insertional tendinopathy. So we kind of see we can do a bilateral single and then a single leg exercise with the knee bent. So we have on the left, we have the bilateral, which is about half body weight per tendon, and then we have here a full body weight with the knee straight, so we're loading the gastroc, and then if we want to isolate the soleus, we can flex the knee. But what I want you to notice here is the dosage. So when you look at the exercise dosage, what do you see? And if we look at 3 sets of 15 reps for all 3 of these, then we're looking at a lot of reps. And 2 times per day, 7 times per week. So if we just take a single heel rise and we say, well, that's 45, 2 times a day, that's 90. And if we do both with straight and bent, that's 180 per day, and then we're doing it every day. So this is clearly a high rep, low load, no rest program, because there are no days of rest. We're just kind of hitting that pretty hard, right? And then one more thing is like pain tolerance. Like most people these days that I know allow some amount of pain as part of the exercise, so it's not 100% pain-free. So they use a guideline like below 3 or below 4 or 5, and as long as it's below that, it's okay. And just recognize that with tendinopathy, you don't always have the pain won't occur during the exercise. Oftentimes it occurs afterward. So allow for a delayed response when you're dealing with people with tendinopathy. So one question is, how would you change this exercise for somebody with insertional Achilles tendinopathy? And we'll talk about that in class. And then secondly, so is a high load, low load, high rep no rest program ideal for patients with tendinopathy. This is the most common prescription for patients with tendinopathy that it occurs today, without question. And so the idea is let's start with load. And so is that load enough to cause remodeling? And is it the right load for people who are athletes, which is non-insertional tendinopathy is universally experienced by athletes. And so if we kind of look at the body weight loads from biomechanics that occur in the tendon, we pretty much know that the single leg and double leg exercises kind of match walking levels, but they're really much lower than too low for running or hopping. So they're under dosing from a load perspective. And we can kind of see here's our different exercises on the y-axis, and then body weight load calculated for the Achilles tendon force on the x-axis, and we see a 3, 6, and 9. So we see this first grouping of exercises. They're all pretty much heel rise variations in walking, and essentially we start to go from there to kind of things that are more functional or sports based. There's really just this big jump, and so it would help us to have something that bridged between these kind of heel raises and then some kind of version of these sports related tasks. So here we've got a different study that came out in 2015 that really shook the low load, high rep, no rest programs. Because essentially this particular program was high load, low rep, and 3 times a week. So maximum rest essentially, because they're using like a strength training protocol. One of the things that wasn't done in this study was that they didn't really optimize load. So although it was high load, they really didn't determine exactly how high. It was still left up to the preference of the patient. And so in this particular study, came out in 2015, there was no difference between the high load, low rep program and the low load. I didn't say that right. The high load, low rep, there was no difference in that as compared to the low load, high rep program. So real shocking finding that kind of immediately changed the landscape for Achilles tendinopathy. And so we were interested in extending this work and looking at if we really optimized high load, would that get us to better tendon remodeling? So would that essentially not just get rid of pain, but also help us shrink the size of the tendon so that the tendon restructuring and basically the tendon elastic response was somehow enhanced? And so we knew that this force velocity curve told us how to do it. It's like, well, if we can get in this eccentric zone, essentially we can achieve higher tendon strains and load, and by doing that we might get more cellular kind of remodeling. And we know that essentially that the tendon is low cell, has fewer cells and low vascularity, and so that tendon repair is hard to come by, right? Because they don't have the substrate to reorganize the tendon the same as we do bone and kind of muscle, right? So essentially we came up, or this is not us, we didn't come up with this, but this is a recommended formula in sports medicine that if you use a 1 rep concentric max, that the eccentric max at around the same speed is going to be about 35% higher. So if you have somebody who does a 1 rep max of 100 pounds, you know that their peak ability to do eccentric load is about 135 pounds. And so we could use that estimate to establish start at a training level for patients with Achilles tendinopathy, and that's just what we did a few years back, Dr. Cuddyford, myself, and some of the students at GFU. And so they determined a 1 rep concentric rep max, and then they multiplied that by 135, and then they multiplied that by 80%, and that became the training load. And essentially you'd have a training, so for a 200-pound runner, you'd end up with a training load that started at 248 pounds, and this is a patient from the study basically. And then at the end of training, they were at 480 pounds, and so that they were training at 390 pounds for 10 weeks. And the length of the training protocol was important to kind of give that enough time to get the response in the tendon, given its low vascularity and low cellularity. And so the exact training protocol we'll kind of go over in a minute, but it was, remember, it's high load, low reps, and adequate rest. So another thing that's important is this exercise, this kind of horizontal leg press exercise that we did was basically they went up on two feet and then lowered on one with the weight. Calculating out the tendon force during that exercise, it places it in the 3 to 6 body weight load in the tendon. So it was a nice bridging exercise from these kind of low load activities to these sports-specific activities we have over here. So a good bridge that puts the patient in control. So these are graphs of the exercise load, so the resistance load they trained on the Y, and then the weeks of training here on the X. And so for I think 19 different participants, right? And so a question I'd like to address in class is, what does this graph tell you about what you're going to experience if you apply this same training load to Achilles tendinopathy patients in the clinic? There's a lot of information here about how patients reacted and when they increased their load and when they just stayed at the same load. And so you might look at this and try to anticipate what some of the things you're going to experience if you kind of try to adopt this loading paradigm. Okay, so here's the specifics of the repetitions. So we did essentially 6 to 8 reps, 3 sets, 1 exercise. So just 24 reps, that's it. And we kept the knee straight, or mostly straight. It wasn't perfectly straight, it was slightly bent. But that was it, just 1 exercise. And as soon as they hit 24 reps, we progressed the weight. And so, and then this graph here, we're showing you the newtons of strength that they started off with. So this is their pre-test. And so the healthy controls are here in the blue, dark, and then the hashed is the Achilles tendon participants. And you can see there was a significant strength deficit at the beginning of the study, and this is their concentric 1 rep max. By the end of the study, so after 10 weeks, we can see both groups had a marked improvement in strength, almost exactly equal. But it was interesting that the AT started so low that they didn't even get back to the median value wasn't even back to the same value as the control group at the beginning. So still some room to improve. Now, one of the main hypotheses had to do with tendon thickness, and so here we can kind of see the ultrasound probe, which was used to grab width of the tendon, and we can see this pre-test here. It's over the kind of largest part of the tendon, proximally. We see this increased width of about 0.63 centimeters, and at the end, the same person at the end of the study, significant decrease in width. And so here we have a tendon width pre and post. We can see the controls were right around 0.4, and they stayed the same, which makes sense. And there was a significant decrease in tendon width in the AT participants, still having less change, and then about half, though, like all these people down here, nearly half of the participants were within the range of the controls at this point, suggesting a really good effect, at least on half of the participants. And then finally, what about their self-report of how they felt about the program? And remember, this is just doing 1 exercise, nothing else, and they're able to do their sports activities at whatever level they liked. And this is using the Visa A, which is specific for Achilles tendinopathy disability. They started off at a fairly low rating of 65.1, 100 being a perfect score, and they had a significant improvement post-training, and that was retained at 6 and 12 months. So quite a good outcome, nearly a perfect score, starting right after training. Again, some nice questions for us to think about in class. Okay, and so that's a nice program that bridges between these kind of low levels of exercise and heel rises and then more sports-specific tasks. But what about return to sport? Because all these individuals want to do sports and participate. Here's some things to consider. Questions to ask is, how's the person's body responding? Meaning the tendon responding to the load and the exercises that they want to do. Are there still impairments that you can measure so you can detect that you want to remediate? And how much load is the tendon tolerating? So one of the things that we'll kind of see on the next slide is when you're assessing people with tendinopathy, it's really important that they're kind of exposing themselves to load, because if they're not exposing themselves to load, they are probably asymptomatic. But they may still have some subclinical potential to have pain. So if they're not active, then you don't know if the tendon's actually healing or not. You just know that it's not symptomatic with low load. You need to assess them with the proper exposures to know if they're really doing better or not. So this kind of gives you some framework. So pain and symptoms here, asking is it is acceptable to exercise and load the Achilles tendon even if it's painful. So you're going to monitor the pain, but it has to be within a certain range, so not over 5 of 10. It's important to evaluate pain and symptoms the day after tendon loading activity, especially in the later stages of return to sports. So you have to be ready for this kind of rebound effect that occurs. So basically making sure that you have incremental loading, especially when you're transitioning back to sports, because it's easy to kind of overshoot, and then they have a rebound effect because they're not feeling symptoms at the time they're doing the exercises. And then just like we saw in the study, there were people with significant strength deficits that you may have to extend the impairment-based treatment to get them back to sports activities where they're not compensating with hip or knee function. And then finally, just being aware of the speed and the type of activities you're asking them to perform. For example, going from our bridge exercise, which is one exercise of high load, it was very slow, so it doesn't have like the stretch shortening cycles that you would get during running. It's also potentially lower than something like a hop if it's significant height or a burst of activity. So even though it's a very high load and it's kind of conditioned over time, you're making the transition from that to sports might require an additional step. So some guidelines you can kind of see here. This is from Karen Silbernagel's work, and suggests that these kind of guidelines for pain, and you can read them, where it's safe in the 0 to 2, an acceptable zone is less than 5, and then high risk zone is above 5. And then when you're thinking about that, though, is try to classify what their level of activity is. So essentially, a light amount of activity or kind of pain response is kind of here. And then you have a medium and high. And then what's happening with respect to what their current activity is or what you're asking them to do. Are they, if they're walking for 70 minutes, then a light amount of pain should be acceptable. If they're at 85% of their sports-specific activity, then it may be acceptable that they have some kind of high level of symptoms, as long as it's resolving the next day. So you're trying to assess symptoms with respect to the loading that they're being exposed to. So in this particular study, what I wanted to show you, this was a really innovative internet-based study that was done by a large group of people, but led by Ruth Chimenti from Iowa. And essentially what they were looking at is kinesiophobia, and they asked people on the internet to fill out the kinesiophobia form, and they ended up and asking them to do a couple activities. And you can see the activities that are heel rise and 3 hops. And they had them self-report their tendon pain, and then they were kind of in this kind of mid-range age group. So what they found was about 72% of the patients with Achilles tendinopathy reported kinesiophobia, so really high number. But importantly, they also found that there was very little evidence of nociceptic pain or nociplastic pain. And so meaning that they still had kind of peripheral pain mechanisms at play, but they were, even though that they had fear of movement. So here's kind of what it looked like. Part of it was their willingness to do the exercises. So they asked them to do these 2 exercises, heel rise and a single leg heel rise and 3 hops. And half of the respondents were unwilling to complete the tendon, they called them tendon loading exercises, the loading exercises. And, the reasons were given is fear of injury, they just were too painful, and then location. But location didn't mean location on their body, it just meant that when they read the survey online that they were not in a good location to do either one of these, so they just decided not to do it. And then a small percent said they're unable. So it's pretty interesting that that the tendinopathy is significant enough that it affects their interpretation of their abilities and their willingness to do it, which may be why they seek help from physical therapy. Now, in this next study, also done by Dr. Chimente from Iowa, what she was looking at is in patients with Achilles tendinopathy, does a pain neuroscience approach better than just an anatomical explanation of the pain and the pathology in the tendon. So kind of, hey, I'm giving you a biomedical explanation of what's going on versus, hey, here's a pain neuroscience explanation of what's going on. Does it matter in terms of improving kinesiophobia, which is the Tampa kinesiophobia scale here, and then the number of heel raises here. So you can kind of see the pain science versus the anatomic explanation. There was really no difference after 8 weeks in either group. They both had improvement in lowering of their kinesiophobia, and they also both increased their amount of heel rises. So there's really no effect. And so in this particular study, that they found as these findings support clinicians to make a person-centered decision on which educational approach is best to combine with exercises for their patients. So they both kind of worked. So where does this leave us looking at tendinopathy? There's this nice classification study that just came out a year or so ago, and JOSPT says we have really 3 different kind of ways to look at patients in tendinopathy. And what we're seeing here is a plot of different assessments that we might make. So we'll start over here in the purple. These are all assessments that are pathological, like of the structure of the body. So the shear modulus, which is the elasticity of the tendon, and another measure, viscoelasticity of the tendon. Here's the cross-sectional area of the tendon, so how big the nodule was, and then a different measure of how big the nodule was in terms of thickness. So that's what we measured. So this is all structure. This is all has to do with structure and function of the tendon itself. Then the green here are capacity tests that we would do. So this is a counter movement jump from height, and this is a drop counter movement jump. So these are both kind of functional capacity tests we would use. Here's a heel rise test. At this moment, I'm forgetting the pass, but that's another physical capacity test. So these are all capacity tests. And then we have just structural BMI of the patient. This is a fear avoidance questionnaire. Here's the VISA-A self-report, the amount of pain they have with hopping, and here's pain catastrophizing and kinesiophobia. So what we can kind of see is this person really doesn't have any one of these dominant. They just have a little bit of pain catastrophizing, some pathology, some subtle restrictions on capacity tests, and so they're an activity dominant person. So they're just not trying to not stay active as a way of managing their problem. Now, a psychosocial dominant kind of person, we know what the wheel is now. We can kind of see they don't really have much pathology because this black line, their scores on all these exams don't kind of delve into the purple over here, but essentially they have real low scores on their capacity tests, and then they also have scores on their pain catastrophizing and kinesiophobia tests, and then they have symptoms, right? So this person's really psychosocial dominant, but not pathology is not really part of it. Okay, and then finally, over here, what we can kind of see is there's a lot of different changes that they're experiencing in terms of pathology. So this person might be somebody that is insertional tendinopathy, or they have a larger kind of deformity in their tendon for non-insertional tendinopathy. And then they don't have much overlay in terms of pain catastrophizing, kinesiophobia, or pain, but then they also have some trouble on their capacity tests. So structure dominant. So these three kind of categories of patients is kind of a way of thinking about how patients react to these different situations, and how we as providers would have to kind of vary the treatment for each one of these scenarios. So here's some study questions to think about. And now we'll go to posterior tib, which some of this I presented in 2018. So posterior tib, we're going to break down into stages, and then we're going to talk about plantar fasciitis, and we're going to be out. So just to review is, remember that the arch raising and lowering has a lot to do with the internal structures of the foot and the rotation of the tibia. And just keep that in mind. And then we also know that from this old experiment that you can load the foot a lot and the arch will be maintained even though there's a lot of weight on it. And finally, we know that muscles do matter, though, because we know that when we measure EMG in the foot, extrinsic, intrinsic muscles, that there's a lot of activity during movement. And essentially what we think is that during gait, we know that 80% of the function of gait is supported by plantar flexion of the foot and ankle. And so we know that there's this loading of the plantar flexors in the foot throughout the stance phase of gait, and then during push-off, where during the stance phase early before the heel comes up, we know it's shock absorption and ground contour. And then after that, we know that it's all about ankle power. And so the muscles really control the flexibility of the foot by inverting and everting the foot and adapting the foot to the ground surface. So this is what we're going to run across when we start to look at foot problems. Like this is a case of severe pronation with hindfoot eversion, medial collapse of the arch with even potentially some talar adduction that's occurring, and too many toe sign as we see the abduction of the forefoot here. And this is the severity of kind of foot function that we see on X-ray. But even in the presence of that kind of deformity, we can still have a lot of foot function at the different joints of the foot. So part of our job is to kind of see, what is functioning and how can our patients take advantage of what is working within the foot. And so we can have patients start in a sitting position and stand and look at the difference in the arch height using the navicular drop test, or just observing how much the medial longitudinal arch changes or the rear foot changes. We can also look at the radiographs and get a sense of what the different positions of the midfoot and hindfoot are. We can use the foot posture index, which if you haven't learned that yet, or you need to review it, here's a link. And then we can use the windlass test to kind of know how the plantar fascia is functioning. And finally, we can kind of look at the midfoot instability by checking the talonavicular motion, and then big toe extension, and then we can use some kind of standard wall assessments, and then at a functional level. So this is just to kind of illustrate how the plantar fascia is kind of a robust effect on the foot, even in the presence of pathology. So in this particular study, we're looking at people with diabetic feet that the windlass mechanism still sustained. So we have these three different deformities. We have one where the talus here is, this top line is in line with the metatarsal, that's the bottom line. They're pretty much lined up. And then here we have, there's more plantar flexion of the talus and dorsiflexion of the first metatarsal, so the lines don't match up, and we see this 19 degrees of dorsiflexion. And here there's a lot of plantar flexion and vertical alignment of the talus, and then the metatarsal is now dorsiflexed like 35 degrees. So And then when we look at the bottom row, in each case, what's just happened is they've cocked up the first metatarsal and then re-looked at the radiographic alignment. What we can kind of see here, in each case it improves a bit, but in some cases more than others, and that's the effect of the plantar fascia kind of raising the medial lungeal arch or improving alignment of the foot. And here in in participant B, it's a 9-degree effect. I got a 4-degree on the first one and a 2-degree on the last one. So that's the windlass effect. The other thing is just to note that there's significant weakness associated with some of these tendinopathies. So even though it's a tendinopathy, the main part of the muscle's also being affected. So this is some studies I did when I was younger. Essentially was showing that there was symmetry in the posterior tib strength and controls. And then when we looked at the posterior tib individuals, that on average there was a 20% deficit, and then there were people, like half of the people had deficits that were ranging from 40 to 80% of the uninvolved side. So quite significant strength problems can occur, and we can capture that nowadays with ultrasound to kind of measure the girth of some of these intrinsic muscles, or we can also do some kind of external tests like this paper pull test, which is pretty cool. You can kind of slide a piece of paper under the toes, the small toes or the big toes, and have this patients try to keep you from being able to pull it out. It's a nice external cue for the patients. They relate to their inability to hold the paper in place, and it can motivate them to try to regain strength. And this is kind of just some data on just the extent to which muscle atrophy is occurring in the foot and ankle during things like ankle fractures, posterior tibial tendon problems, plantar fasciitis that's caused a lot of inactivity, flat foot kinds of problems, hallux valgus, and then we already said ankle fractures. And this is based on a study here that Marcy Kiefer-Hutchinson and I did a few years back. And here's some exercises that are critical for you all to kind of understand. People expect you to know these in the clinic. The one is the doming exercise, this kind of TheraBand exercise for posterior tib, and this third exercise, which is maintaining the arch while you twist the trunk. Let's show you the doming exercise here. You can kind of see the person's going to pull their first metatarsal head back toward their heel, and in effect doming their arch. And then they'll do it again here in a minute. And this is kind of an awareness exercise, or an exercise that makes you understand how to control your midfoot. And then a strengthening exercises which targets the posterior tib is this therotubing exercise with the legs crossed and the ankle plantar flex. So that plantar flexion of the ankle aligns the posterior tib, which you can kind of see the tendon popping out here, with the vertical, and then you have the person wag the foot upwards, which gives you forefoot adduction, which is a main role of the posterior tib at the midfoot. And so that really isolates the posterior tib, and then you can tighten the band up and get quite a bit of load on there to kind of push the tendon for remodeling. And this last one here is the standing posture exercises. You have the people, individual, maintain the arch of the foot while they internally rotate. The internal rotations kind of causing the arch to want to fall, and you're asking them to maintain their muscle control and not let the arch fall while they internally rotate. Now, that's not what was novel about this exercise program that we did with the George Fox students here a few years back. It was more this inclusion of barefoot walking in these people with flat foot. So we asked them to barefoot stand or walk around their house for an hour 5 times a week, in addition to doing the exercises. And then we assessed their foot function during a variety of tasks afterward. And it was impressive how much heel rising improved, some walking variables improved, and they had some relief of their foot symptoms. So it was a really fun study to do, and the patients really benefited. So when you're looking at heel rises, though, one of the things I just can't emphasize enough is it's not easy to understand how the midfoot's functioning just because it's hard to see. So by getting heel height and measuring that, it gives you a sense that the medial lungeal arch is working. It's not just the motion, but the muscles are actually controlling it correctly. And so you know that if the arch is raising, then those muscles are working, so the heel height's achieved. And 50% of raising is due to the control of the medial lateral arch. So that having equal heel heights is an indicator of that. And then when you look at repetitions of heel raises, make sure you reference normal values. If you notice in this kind of normative chart, I think in 500 individuals, that 20-year-olds, males, have significantly different average heel rises, repetitions than 60 to 80-year-olds. So now, before we really dive into posterior tib tendinopathy, we want to kind of review the function of the foot muscles. That's extrinsic foot muscles. So we have the posterior tib, which inverts the subtalar joint, and at the midfoot, or the talonavicular joint, it adducts and plantar flexes, and then both of which help raise the MLA. Now, its partner in crime is the fibularis longus, which everts the subtalar joint, so an antagonist there, but it really is a synergist when you look at the midfoot. So the fibularis longus plantar flexes the talonavicular joint, also raising the arch. The other structures that help raise the arch are the plantar fascia, long, short plantar ligaments, and the spring ligament. So when we look at the tendon itself, we know that it runs posterior to the milli malleoli and then attaches on the navicular tuberosity, and so we can kind of see how that would support the medial longitudinal arch. And when we look at it at surgery for posterior tib tendinopathy, we notice that it's much larger than it should be, and it's discolored as it runs underneath the tarsal tunnel. Okay, so now we want to look at is the stages of posterior tibial tendinopathy. So we notice that stage 1 is really signs of tendinopathy that are specific to the tendon, and then in stage 2, we're going to notice is that we have tendinopathy signs and forefoot or hindfoot deformity that's mobile. Okay, so if we look here, we can say we have a person that's got some greater eversion on the right than the left, and less medial longitudinal arch on the right than the left, so there's deformity. And then if we have signs of tendinopathy, which is pain along the tendon and pain provoked by manual muscle testing, that would indicate stage 2 deformity. And then we'd confirm that by noting that the mobility of the subtalar joint could be restored to neutral, or in standing, we could have this person on the right leg invert their hind foot and return the alignment of the foot while keeping their first metatarsal on the ground, and that would indicate that the arch could be raised and the rear foot could be returned to normal without, so that that can be corrected, basically. And so that's a mobile deformity or a flexible deformity. So that's definitely. So what we know is that the part of these deformities is caused by the loss of this ligamentous support, but there's still, which makes the midfoot joint unstable. We still have some muscular support, and where we have muscular support, we can still improve function non-operatively. And so when we look at stage 1 and 2, these two stages, we still have, there's enough function left for the muscles because the joints can still move through their full range of motion. But if we go to stage 3 and 4, we need bracing and surgery to improve their abilities. So in this particular example, we're showing you the x-rays that you can use to assess foot function, and we have a normal x-ray on the left, which you can see the first, the talus neck here is aligned with the first metatarsal, and then we see a good calcaneal pitch angle with the horizontal, and then the fat pad. That gives us a nice MLA. We look on the right, we can see here is that the talus is now plantar flexed a little bit. There's some dorsiflexion of the first metatarsal, and the calcaneal pitch is lost, meaning there's lowering of the medial longitudinal arch. So this is typically what we see with posterior tib is more like this picture here, where the deformity of the hind foot and forefoot are fairly severe, where we see the subtalar eversion, the bulging in the medial side of the foot, and the lateral too many toe sign. And then on the medial view, we can kind of see the enlargement on the medial side of the foot, which includes the increased hypertrophy of the tendon itself, and also the adduction of the talus kind of protruding out, and then the abduction of the forefoot leading to this like large protrusion on the medial side. What this might look like at the subtalar and talonavicular joint is illustrated in these radiographs. We can see the normal radiograph here on the left, which is halfway through the ankle. So we can see the ankle mortis, including the fibula, the talus, and then the calcaneus. And then in a patient with posterior tib dysfunction with severe eversion, we can see how the calcaneus here has slid up and made contact with the fibula, and that's an impingement problem, indicating possibility of lateral pain in somebody with a medial joint problem. On the right side here, we see the talonavicular joint alignment. So here's the talar head here, the first metatarsal. The alignment's pretty good, and so this is a normal with X-ray. If we look on the right side, we look closely at the talus here. We can kind of see that the talus is adducted, and so the navicular is slid laterally, and so the forefoot follows, and so this is how we get the too many toes sign, this whole forefoot abducted position while the talus is adducted. So I'll let you watch these videos. You can see these are videos of heel rises for a person, the same person with stage 2 posterior tibial tendon dysfunction. So when pretty minimal deformity really, and standing and able to correct that deformity during the heel rise task. And here in this person, we have the involved and uninvolved side. With stage 3 deformity, they're really unable to perform the heel rise at any functional level. You'll see a significant decrease in height, indicating there's instability of the midfoot and inability to stabilize the midfoot to perform a successful heel rise. And then this is really a stage 3-4. And what I'm showing you in this first picture is I positioned the person's subtalar joint neutral, but then notice that the first metatarsal head's off the ground. So what that's indicating is that the person has a fixed deformity, is unable to plantar flex the first metatarsal head when the subtalar joint's in a neutral position. And then we'll watch the video here and see if you think that the motion's coming from the midfoot or from the ankle joint. And you can see that there's almost no motion coming from the ankle joint. It's all eversion of the midfoot, and then the heel rise is accomplished through knee flexion. And then here, the same person during gait. And that was kind of shaky, so we'll do it again. Okay, and there you see the single leg stance, and the other foot's off the ground a little bit, and you can kind of see that there's a significant amount of eversion of excessive 20 degrees, and the too many toes sign where we have that abduction of the forefoot. So a good example of a stage 3-4 posterior tib tendon dysfunction or acquired flat foot deformity. One more time. Okay, so what the stage 4 is really reserved for when involvement starts to become at the ankle joint. So you can see how there's all that stress from the eversion on the medial side of the ankle. So if the deltoid ligament starts to become dysfunctional or it stops stabilizing the mortise of the ankle, then you could get something that looks like this x-ray, and then you have to move toward realigning the foot and or fusing the ankle. And you can kind of see the triple arthrodesis procedure shown here, where you fuse the subtalar joint, the talonavicular, and the calcaneal cuboid joints. and then we'll do these cases in class, potentially.